In this video, we'll be explaining in detail about the regional structure and function of your cervical spine. That is the kinetics and kinematics of your cervical spine. So in the cervical region, it consists of 7 vertebrae in total, and morphologically and functionally, the cervical column is divided into 2 distinct regions. So the cervical area or cervical region has been classified into 2 specific or 2 distinct regions. They are the upper cervical spine, otherwise known as craniovertebral regions, and the lower cervical spine. So it has been divided into 2 regions, that is upper cervical spine, otherwise known as craniovertebral region, and the lower cervical spine. The upper cervical spine or craniovertebral region consists of your occipital condyles, C1 that is your atlas, and C2 that is your axis. And lower cervical spine consists of the vertebrae from your C3 to C7, that is C3, C4, C5, C6, and C7 vertebrae. The vertebra from C3 to C6 display similar characteristics, and they are known as your typical cervical vertebrae. So the typical cervical vertebra are your C3 to C6, that is C3, C4, C5, and C6. The atlas, axis, and C7 exhibit unique characteristics, and they are considered as atypical cervical vertebrae. The atypical cervical vertebrae includes your C1, that is your atlas, C2 that is your axis, and C7. All of the cervical vertebrae have unique feature of a foramen, that is the transverse foramen on the transverse process, because for the passage of the vertebral artery. So in order for the passage of vertebral artery, in the transverse process, there will be one foramen known as your transverse foramen. That is one of the unique feature or peculiar feature for your cervical vertebra. So this is the diagrammatic or pictorial representation of your regional variations in the cervical vertebrae. That is the upper cervical vertebra or craniovertebral region and the lower cervical spine or lower cervical vertebra. And the surrounding or the supporting ligaments that restricts or the prevent excessive motions of the cervical spine during your flexion extension, lateral flexion, and the rotation. So first region, that is your upper cervical vertebra, that is a craniovertebral region, and the first bone is known as your atlas, that is the C1. It is frequently described as a washer sitting between the occipital condyle and the axis, that is a C2 vertebra. The functions of the atlas are to cradle the occiput and to transmit forces from the occiput to the lower cervical vertebrae. Mainly the function of the particular atlas or C1 is to hold the occiput and transmit the compressive forces of the head or weight of the head from the occipital region towards the lower cervical vertebra. The atlas is different from the other vertebra because it has no vertebral body or spinous process, and it is shaped like a ring. So the atlas doesn't have any vertebral body and spinous process, and it will be shaped like a ring. So it is like a ring-like structure, atlas. There are 2 large lateral masses on the atlas that have a vertical orientation to each occipital condyle, which reflects the function of transmitting forces. The lateral masses are connected by an anterior and posterior arch, which are together forming the ring structure and also create a large transverse process for the muscular attachments. The transverse process also contains a foramen for the passage of the vertebral artery. So in the previous slide, we already discussed regarding the unique feature of the cervical spine, that is the transverse foramen, and which will be responsible for the passage of the vertebral artery, or through which this foramen, the vertebral artery, will be getting passed. And the lateral masses includes the 4 articulating facets, 2 superior facets, and the 2 inferior facets. So this is the peculiar feature of the atlas, that is the C1 vertebra, and it has 2 lateral masses. So that includes these 2 lateral masses on the right and the left that will be articulating with the condyle of the occipital bone, that is a skull bone, and then they will be forming the atlanto-occipital joints. And this articulating surface has the articulating facets, that is 4 articulating facets, 1, 2 on the both sides, right and left superior facets, and right and left inferior facets. So this is the diagrammatic representation of your axis. So in this, you can able to see the inferior apophyseal facets and this transverse foramen through which your vertebral arteries will be getting passed and the transverse process. And this is the facet for dense articulation or the odontoid process of your axis. And this is the lateral mass, and this is the superior zygapophyseal facet. So apophyseal facet. So in this facet, your occipital condyle will be articulating and forming the atlanto-occipital joints. The superior zygapophyseals are large, typically kidney shaped and deeply concave to accommodate the large convex articulate surface of the occipital condyles, hence forming the atlanto-occipital joints. The inferior zygapophyseal faces are slightly convex and are directed inferiorly for articulation with the superior facets of the axis. The inferior articulate facets are convex. So in this diagram, you can able to see here the inferior facets are convex and the superior facets are concave. The superior facets, the concave superior facet of the atlas articulating with the convex condyles, occipital condyles, forming the atlanto-occipital joints. That is the concave or convex joints. And exactly opposite here, it will be convex in structure. The inferior facet will be convex in structure and articulating with the concave superior facet of the axis to form the atlanto-axial joint. So that will be convex or concave. Here it will be concave or convex. The atlas also possesses a facet on the internal surface of the anterior arch with the arch for articulation with the dens, that is the odontoid process of the axis. So this is this particular facet that will be articulating with the odontoid process or dens of the axis. Next bone is your axis, that is the C2 or second cervical vertebrae. The primary function of the axis are to transmit the combined load of the head and atlas to the remaining cervical spine, and it provides motions to the axial rotation of the head and atlas. The axis is a atypical vertebra in that anterior portion of the body extends inferiorly and a vertical projection called dens arises from the superior surface of the body. The dens has an anterior facet for articulation with the anterior arch of the atlas and a posterior groove for articulation with the transverse ligament. The arch of the atlas has an inferior and superior zygapophyseal facets for articulation with the adjacent inferior vertebra and with the atlas respectively. The spinous process of the axis is large and elongated with a bifid, that is, it has been split into two portions. This spinous process of the axis will be having bifid tip. The superior zygapophyseal facets of the axis face upward and laterally, and the inferior zygapophyseal facets face anteriorly. So this is the diagrammatic representation of your axis bone. So you can see in the lateral aspect and in the superior aspect, in the oblique view, you can able to see the dens, that is the odontoid process. So that articulates with the axis. Coming to the articulations, the two atlanto-occipital joints consist of two concave superior zygapophyseal faces of the atlas articulating with the two convex occipital condyles of the skull. These joints are true synovial joints with an intra-articular fibroadipose meniscoids and lie nearly in the horizontal plane. There are three synovial joints that compose the atlanto-axial joints. So the articulation over the craniovertebral region includes your atlanto-occipital joints and the atlanto-axial joints. So first articulation is the atlanto-occipital joints, that is formed by the two concave superior faces of the atlas articulating with the two convex occipital condyles, forming a concave or convex joint. So, and these joints are true synovial joints. And the other joint, the second joint in the craniovertebral region is your atlanto-axial joint, that is formed by the atlas and the axis. Your inferior facets of your atlas articulating with the superior facet of your axis to form the atlanto-axial joint. And these three joints over here, atlanto-axial joints, are your medial atlanto-axial joints that is present between the dens and the atlas, and the remaining two lateral joints that is present between the superior zygapophyseal facets of axis and inferior zygapophyseal facets of the atlas. So the atlanto-axial joint structure is formed by the combination of three joints, that is the medial atlanto-axial joint and two lateral atlanto-axial joints. The median joint is a synovial joint or trochoid pivot variety in which the dens of the axis rotates within an osteoligamentous ring formed by the anterior arch of the atlas and the transverse ligament. The two lateral joints appear on the basis of a bony structure and they are known as plain synovial joints. The medial atlantoaxial joint is a pivot variety and the lateral atlantoaxial joint is a plain synovial joint variety. So this is the atlantoaxial articulations. You can see here this is the medial atlantoaxial articulations and this is the left lateral atlantoaxial and this is the right atlantoaxial articulations. The inferior facet or zygapophyseal facet of your atlas articulating with the superior facet of your axis to form the facetal joints. Two facetal joints on the two sides and the single medial atlantoaxial articulation in the anterocentral aspect of the vertebral column. So this has been supported by your transverse ligament. Next is the craniovertebral ligaments. What are the ligaments that is supporting the craniovertebral region or craniovertebral joints? So four of the main ligaments are continuations of the longitudinal tract system. The four remaining ligaments are specific to the cervical area. The posterior atlanto-occipital and the posterior atlantoaxial membranes are the continuations of the ligamentum flavum. Their structure, however, varies from the ligamentum flavum in that they are less elastic and therefore permit a greater range of motion, especially into rotation. As you know, in the ligamentum flavum is more of composed of elastin. Because of that elastin, they are highly elastic in structure. And in this cervical region, the ligamentum flavum, the continuation of the ligamentum flavum is known as your posterior atlanto-occipital and posterior atlantoaxial membranes, but they are less elastic compared to the ligamentum flavum of the remaining areas, that is your thoracic and lumbar areas. So they permit a greater range of motion, especially in the rotation range of motion. The anterior atlanto-occipital and the anterior atlantoaxial membranes are the continuations of the anterior longitudinal ligaments. And the tectoral membrane is the continuation of posterior longitudinal in the upper two segments and is broad, strong membrane that originates from the posterior vertebral body of the axis, covers the dens and its cruciate ligament and it inserts at the anterior rim of the foramen magnum. So these are the ligaments or continuations of the longitudinal tract system. That is your all the ligaments. That is your posterior atlanto-occipital and posterior atlantoaxial membrane, anterior atlanto-occipital and anterior atlantoaxial membranes, and the tectoral membranes. These are the four ligaments that is common, or that are the extension of the normal longitudinal tract system ligaments in the remaining areas. Similarly, there are specific ligaments that are attached particularly for your cervical areas. So that is your atlanto-cruciform ligament, alar ligaments, and the apical ligaments. So next is the ligamentum nuchae. So ligamentum nuchae is an extension of the supraspinous ligament with a thick triangle sheet-like structure, the base of which it is attached to the skull from the external occipital protuberance and foramen magnum, and the apex, which is attached to the tip of the C7 spinous process. So this is the extension of the supraspinous ligament. So the main function of the ligamentum nuchae is to resist the flexion of the head and serving as a site for muscular attachments. Next ligament is the transverse ligament. It stretches across the ring of the atlas and divides the ring into large posterior section for the spinal cord and a small anterior space for the dens. The posterior part of the dens is covered by this or protected by this particular transverse ligament in order to prevent the compression of the spinal cord. The transverse length of the ligament is about 21.9 millimeter. The transverse ligament has a thin layer of articular cartilage on its anterior surface for articulation with the dens. Superior longitudinal fibers of the transverse ligament extend to attach to the occipital bone and inferior fibers descend to the posterior portion of the axis. The superior longitudinal ligament of the transverse ligament will be extending or attaching to the occipital bone and inferior fibers will be attaching over your posterior part of your axis bone. The transverse ligament and its longitudinal bands are sometimes referred to as atlantal cruciform ligaments. And the transverse portion of the ligament holds the dens in close approximation against the anterior ring of atlas and serves as an articular surface. So this is the transverse atlanto axial ligament or atlantal cruciform ligament. So this is formed by the transverse band, superior band and inferior band. So inferior band will be attaching over the axis and superior band will be attached over the base of the skull, that is your occipital condyles. The main function is to stabilize or hold the axis over the atlas. Its primary role is to prevent the anterior displacement of C1 on C2. It prevents the anterior displacement of atlas on the axis. This ligament is critical in maintaining the stability at the C1 or C2 segments. Its superior and inferior longitudinal bands provide some assistance in this role. The transverse atlantal ligament is very strong and the dents will fracture before the ligament will tear. So if a fracture is occurring in this particular region, there will be a fracture of the bone, that is the dents, but the ligament will be in a stable position or the ligament will not be getting torn because this ligament is even more strong as that of the bone, that is the dense region of the axis. The integrity of the transverse ligament can be compromised, however, particularly with diseases such as the rheumatoid arthritis and conditions such as the Down syndrome. In some conditions, this ligament will be getting weaker or the ligament strength will be getting compromised in particular conditions such as your rheumatoid arthritis and the Down syndrome. Next ligament, specific ligament to the cervical region is your alar ligament. So these are also specific to the cervical region. This paired ligament arises from the axis on either side of the dents and extends laterally and superiorly to attach to the roughened areas on the medial sides of the occipital condyles and to the lateral masses of the atlas. The ligaments are approximately 1 centimeter in length and about a pencil weight in diameter and consist mainly of collagen fibers arranged in parallel. So alar ligaments are approximately 1 centimeter in length and it has a width of a pencil and it consists of mainly of collagen fibers which are arranged in parallel. These ligaments are relaxed when the head is in neutral position and they are tight in the neck flexion. So these particular ligaments, alar ligaments, are tight or taut in the neck flexion and relaxed in the head in neutral position. Axial rotation of the head and neck tightens both the alar ligaments. So rotation of the particular cervical region will be responsible for tightening of these alar ligaments. So you can able to recognize the function of these particular ligaments. The main function of this alar ligament is to prevent the excessive rotation of the cervical spine. The right upper and left lower portions of the alar ligaments limits the left lateral flexion of the head and neck. The left lateral flexion of the cervical region will be prevented by the right upper portion of your alar ligament and the left lower portion of your alar ligaments. This ligaments also helps to prevent the distraction of C1 on C2. The excessive distraction force of atlas on axis will be prevented by these particular alar ligaments. So the main function is to prevent the excessive rotation of the cervical spine as well as to prevent the excessive distraction force of atlas on the axis. The alar ligaments are weaker than the transverse atlantal ligaments. Next ligament that is specific to the cervical region is your apical ligaments, that is connecting the axis and the occipital bone of the skull. So it is a fan-shaped arrangement from the apex of the dents to the anterior margin of the foramen magnum of the skull. So till now we had discussed about the anatomical features of the craniovertebral region or the upper cervical region. Next we will be going for your lower cervical region. So that is the first we will be discussing about the features of a typical cervical vertebra in the lower cervical region. In the typical cervical vertebrae, the body will be small with a transverse diameter greater than its anteroposterior diameter and anteroposterior height. The transverse and anteroposterior diameters increases from the C2 to C7 with a significant increase in both diameters in the upper plate of the C7. The posterolateral margins of the upper surfaces of the vertebral bodies from C3 to C7 supports unkinate process that gives the upper surface of this vertebrae a concave shape in the frontal plane. So this is one of the unique features of your cervical spine, and this process is known as unkinate process. So in unkinate process in the frontal plane, you can able to see this particular cervical vertebrae in a concave shape manner. And the unkinate process are present prenatally and between 9 to 14 years of age, and they gradually enlarge. Next is the pedicles. So these are the features of the body of the lower cervical vertebra, that is the C3 to C7. Next is about the pedicles of lower cervical vertebrae. The pedicles project posterolaterally and are located halfway between the superior and inferior surface of the vertebral body. So this is the diagrammatic representation of the typical cervical vertebrae. So you can see here the spinous process will be bifid and the vertebral foramen will be larger. And you can see here the superior, this is the superior view, and you can see here the superior articular facet that will be articulating with the inferior articular facet of the superior vertebra. And this is the unclinate process. So that is the unclinate process, that is one of the unique feature in the cervical spine. There is a lower cervical spine, and you can see here there is some projections over the lateral aspect, that is known as the unclinate process. And the lamina are thin and slightly curved. They project posteromedially. And coming to the facets, articular process of the psychopophyseal, superior and inferior. This articular process supports paired superior and inferior facets. The superior facets are flat and oval and facing superiorly and posteriorly. They lie between the transverse and frontal planes. The width and height of the superior faces gradually increase from C3 to C7. Inferior facets face inferiorly and anteriorly, and they lie closer to the frontal plane than to the superior facets. The superior facets of C3 and C7 are more steeply oriented than the others. Coming to the transverse process, a foramen is located in the transverse process bilaterally for the vertebral artery, vertebral vein, and venous plexus. And there is a groove for the spinal nerves, for the passage of the spinal nerves. And coming to the spinous process, the cervical spinous process are short, slender, extend horizontally, and have a bifid tip. The length of the spinous process decreases slightly from the C2 to C3 and remain constant from the C3 to C5 and undergoes a significant increase at the C7. So the spinous process will be short, slender, and they will be having a bifid tip, and they will be extending horizontal manner. Vertebral foramen is relatively large and triangle to accommodate the large spinal cord. In this diagram, you can able to see the vertebral column is large and almost triangle in shape. Coming to the intervertebral disc, the structures of the intervertebral disc in the cervical region is distinctly different from that of the lumbar region as well as your thoracic region. Instead of fibrous string completely surrounding a gelatinous center, there is a discontinuous string surrounding a fibrocartilaginous core. The fibers of the annulus fibrosus are not arranged in an alternating lamellar layers as they are in the lumbar region, and they do not surround the entire perimeter of the nucleus pulposus. Instead, the annulus fibrosus in this region have a crescent shape when viewed from the above, and they are thick anteriorly and taper laterally as they approach the unclinate process. Anteriorly, the annulus fibrosus is thick with oblique fibers in the form of an inverted V shape, whose apex points to the location of the axis of rotation on the anterior end of the upper vertebra. And this is the diagrammatic representation of the intervertebral disc over the cervical region. And you can able to see here the annulus fibrosus and the nucleus pulposus. And the annulus fibrosus have a crescentic in shape when viewed from the superior or when viewed from the above. That is the superior view. We can able to see there is a crescentic shape annulus fibrosus, and they are thick anteriorly and they are taper or thin in the lateral aspect and as they are attaching or they are approaching towards this process that is known as the unclinate process, they are almost in a tapering aspect, that is the tapering laterally. And anterior, the annulus fibrosus is thick with oblique fibers in the form of an inverted Y shape. So inverted Y shape, so it is almost thick, whose apex points on to the location of the axis of rotation on the anterior end of the upper vertebra. Laterally, there is no substantial annulus fibrosus, and posteriorly, and it is only a thin layer of the vertical oriented fibers. So we already discussed that anteriorly this is thick, and posterior laterally it is there is no substantive annulus fibrosus, and posteriorly there is a thin layer of vertically oriented fibers of the annulus fibrosus. Posterolaterally, the nucleus is contained only by the posterior longitudinal ligaments. Fissures in the disc develops along with the unclinate process and become clefts by approximately 9 years of age. These clefts become the joint cavity of what has been known as the unconvertible joints or joints of Luschka. So this is the fissures or the anterior annulus fibrous or the disc of the vertebral column. So this particular region or structure is known as unconvertible joints or unconverted cleft, otherwise known as joints of Luschka. Interbody joints of the lower cervical regions. The interbody joints of the lower cervical regions are saddle joints. In the sagittal plane, the inferior surface of the cranial vertebra is concave and the superior surface of the caudal vertebra is convex because of the unkinate process. The motions that occurs predominantly are your rocking motions, although translatory motions remain available. In the frontal plane, the inferior surface of the cranial vertebra is convex and sits in the convex surface of the caudal vertebra created by the unkinate process. So in the sagittal view, we can able to see the inferior surface of the superior vertebra that is concave and the superior surface of the inferior vertebra will be convex. Similarly, in the anterior view or the posterior view or the frontal view, we can able to see the inferior surface of the superior vertebra is convex and the superior surface of the inferior vertebra will be concave. Next is the apophyseal joints. The apophyseal joints in the cervical spine are true synovial joints and contains fibroadipose meniscoids. The joint capsules are lax to allow a large range of motion. However, they do restrict motions at the end of the available ranges. The joints are generally described as oriented approximately 45 degrees from the horizontal and frontal planes. In other way, they lie midway between the two planes. The orientation of the facets is in between the two planes, that is the frontal plane and horizontal planes. And coming to the functions of the cervical region, that is the kinetics and kinematics of the cervical spine. Although the cervical region demonstrates the most flexibility of any of the regions of the vertebral column, the stability of the cervical region, especially of the atlanto-occipital and atlanto-axial joints, is essential for the support of head and protection of the spinal cord and vertebral arteries. The design of atlas is such that it provides more free space for the spinal cord than does any other vertebra. The extra space helps to ensure that the spinal cord is not impinged on during the large amount of motion that occurs here. Coming to the kinematics, the cervical spine is designed for a relatively large amount of mobility. Normally, the neck moves 600 times every hour, whether we are awake or asleep. The motions of flexion and extension, lateral flexion and rotation are permitted in the cervical region. These motions are accompanied by translations that increase in magnitude from C2 to C7. However, the predominant translation occurs in the sagittal plane during flexion and extension. Excessive anteroposterior translations are associated with damage to the spinal cord. The atlanto-occipital joints allow for primarily nodding movements between the head and the atlas. In flexion, the occipital condyles rolls forward and slide backward. In extension, the occipital condyles rolls backward and slide forward. And there are few degrees of rotation lateral flexion available at this segment as well. So in the atlanto-occipital joints, during flexion, the occipital condyle will be rolling forward and sliding backward. And in extension at the atlanto-occipital joints, the occipital condyles will be rolling backward and sliding anteriorly. So in this diagram, you can able to see during flexion, you can able to see there is a anterior rolling of the occipital bone and the posterior sliding of the occipital bone over the atlas. So this is the kinematics of the atlanto-occipital joints during the flexion. And during extension, it will be exactly opposite. There will be posterior rolling and anterior sliding. And the total motion available in both axial rotation and lateral flexion is extremely limited by the tension in the joint capsules that occurs as the occipital condyles rise up the walls of the atlantal sockets on the contralateral sides of either the rotation or lateral flexions. Motions at the atlanto-axial joints include the rotation, lateral flexion, and the extension. Approximately 55% to 58% of the total rotation of the cervical region occurs at the atlanto-axial joints. The atlas pivots about 45 degrees to either side or a total of about 90 degrees. The LR ligaments limit rotation at the atlanto-axial joints. The remaining 40% of the total rotation available to the cervical spine is distributed even in the lower joints. Lateral flexion and rotation are coupled motions. In the upper cervical segments, lateral flexion is coupled with the contralateral rotation and rotation is coupled with the contralateral lateral flexion. This particular phenomena is known as the coupling motions of your vertebral column. So in this you can able to see here, this is the flexion movement. So during flexion movement, there will be anterior tilting and rolling of the atlas over the axis. So this is happening during the kinetics and kinematics of your atlantoaxial joints, and the kinematics of your remaining or the lower cervical joints. So during flexion, there will be anterior sliding of superior vertebra over the inferior vertebrae. So excessive flexion will be prevented by the ligamentous structure over the posterior axis. That is your ligamented nuchae, interspinous ligament, and your supraspinous ligaments. So similarly, your anterior longitudinal ligaments and annulus fibrosis, anterior annulus fibrosis, and capsules, everything will be getting compressed. The excessive motions will be prevented by all of these structures. So this is the extension. During extension happening at the atlanto-occipital joints, there will be posterior rolling along with the anterior sliding of the occipital condyle on the atlas. And during extension over the atlantoaxial joints, there will be posterior tilting of atlas over the axis. And during extension of the lower cervical joints, there will be posterior sliding of the superior vertebra over the inferior vertebrae. And what are the ligaments that is present over the posterior aspect will be getting slacked, and there will be bony restrictions. Or the spinous process will be approximating each other during the extension, thereby preventing the extremes of hyperextension. And the only ligament that limits the extension is your anterior longitudinal ligaments. So that is the reason why the anterior longitudinal ligament is twice as strong as the posterior longitudinal ligament. Flexion of these segments must include the anterior tilt of the cranial vertebra coupled with the anterior translation. Given the 45-degree slope, tilt of the vertebral body in addition to the anterior translation is necessary to get full motion of these joints. Extension includes posterior tilt of the cranial vertebral body coupled with posterior translation. These are the motions that occurs in the lower cervical regions that we already discussed. So during flexion, there will be anterior tilt as well as the anterior translation. And during extension, there will be posterior tilt as well as the posterior translation. So both your lateral flexion and rotation are coupled motions over your cervical region as well as your thoracic and lumbar regions. So these motions are a combination of vertebral tilt to the ipsilateral side and translations of the apophyseal joints. So this is the lateral flexion of your atlanto-occipital region joints and the intracervical or lower cervical regions. So you can see here during the lateral flexion, there will be some rolling. So rolling and sliding. The rolling towards the same side and sliding towards the opposite side. So accompanied with the some amount of rotation. So during lateral flexion, you can able to see the spinous process is rotating opposite. So during lateral flexion to the right, there will be rotation to the left, rotation of the spinous process. In this, you can able to clearly see the spinous process is rotating towards the opposite side or the contralateral side. So during lateral flexion, there will be sliding of superior vertebra over the inferior vertebra along with the rotation of the one vertebra over the opposite side or towards the contralateral side. So this lateral flexion will be help the muscles which is responsible mainly is your rectus lateralis. So that will be helpful for lateral flexion of your cervical spine. And this is the rotation. So during rotation, you can able to see here one region, this particular region will be sliding posteriorly and the opposite region will be sliding anteriorly. So rotation towards the right, you can see here, there will be posterior sliding of the right side vertebra or right side facet, and the left side facet will be sliding anteriorly. So this is about the rotation or kinematics of the rotation of your cervical spine. Coupling patterns can change with aging. Lower cervical segments generally favor flexion and extension motion. In general, the range for flexion and extension increases from the C2, C3 segments to the C5, C6 segments and decreases again at the C6, C7 segments. The zygapophyseal joint capsules are generally lax in the cervical region which contributes to the large amount of motion available here. The height in relation to the diameter of the disc also plays an important role in determining the amount of motion available in the cervical spine. The height is large in comparison with the anteroposterior and transverse diameters of the cervical disc. Therefore, the large amount of flexion, extension, and lateral flexion may occur at each segment, especially in the young people. The total range of motion of the cervical spine is dependent on many factors, including the age and sex, and there is greater motion in those who are young and female. The disc is at C5, C6 is subjected to a greater amount of stress than the other disc because C5, C6 has the greater range of flexion and extension and is the area where the mechanical strain is greatest. So the greater amount of stress is present over your C5, C6 disc. And coming to the kinetics of your cervical spine, although the cervical region is subjected to axial compression, tension, bending, torsion, and shearing stresses, the cervical region differs from the thoracic and lumbar regions in that it bears less weight and is generally more mobile. So you need to learn one equation that if stability is more means mobility is less, and if mobility is more means stability is less. So no discs are present at either the atlanto-occipital or atlanto-axial articulations. Therefore, the weight of the head, that is the compressive load, must be transferred directly through the atlanto-occipital joints to the articular faces of the axis. These forces are then transferred through the pedicles and lamina of the axis to the inferior surface of the body and to the two inferior zygapophyseal articular process. Subsequently, the forces are transferred to the adjacent inferior disc. The lamina of the axis are large, which reflects the adaptation in structure that is necessary to transmit these compressive loads. The trabecula shows that the lamina of both the axis and C7 are heavily loaded, while the intervening ones are not much loaded. Loads diffuse into the lamina as they are transferred from superior to the inferior articular facets. The loads interposed or imposed on the cervical region vary within the position of the head and body and are minimal in a well-supported reclined body posture. The load over the cervical region is less during the reclined body posture. In the cervical region from C3 to C7, compressive forces are transmitted by three parallel columns. A single anterocentral column formed by the vertebral bodies and disc, and two rod-like posterolateral columns composed of the left and right zygapophyseal joints. The compressive forces are transmitted by the three columns, that is three parallel columns, two lateral posterolateral columns, and the single central, that is the anterocentral column. And the single anterocentral column is formed by the vertebral bodies and the disc, and two posterolateral columns are composed by the right and left facetal joints. The compressive forces are transmitted mainly by the bodies and disc, with a little over 1/3 are transmitted by the two lateral columns. Almost 2/3 or more than 2/3 of the compressive forces are transmitted by the anterocentral column, which is formed by the body and the disc, and almost less than 1/3 of the compressive forces are transmitted by the two posterolateral columns, which is formed by the left and right facetal joints. Compressive loads are relatively low during the erect stance and sitting postures and high during the end range of flexion and extension. The cervical spine has approximately 45% of the compressive strength of the lumbar spine, and it has less than 20% of the bending strength compared with the lumbar spine. So there is a greater bending strength in extension compared to the flexion. Resistance to extension is provided primarily by the zygapophyseal joints and the intervertebral disc, while resistance to flexion is primarily provided by the posterior ligaments between the spinous process. So by this we are concluding the regional biomechanics, that is the kinetics and kinematics of your cervical spine. In the next video we will be discussing about the kinetics and kinematics of your thoracic spine as well as your lumbar spine. So thank you for watching this video. Please do subscribe and share this to your friends. Thank you.